Right. Is everybody in, Adi?
Everybody's in so far, and I'll keep monitoring the room. Welcome everybody to the NEESAMA webinar. Dr. Stuart Watson's the chair, and the meeting is being recorded. Please keep yourselves on mute if possible.
Thank you very much, Adi, and hello and welcome everybody. It's great to have a NEESAMA webinar. It's great to have people coming here from so many different places, and it's fabulous that we've got such fantastic people here to present. So thank you very much, Adi, for organising this. We've got a full program today. So Madhu's is on first from 5:10 until 10:25. We move very quickly from Madhu to Venkat for 20 minutes, and then straight to Shiv through to 11:05, and then we've got a 20-minute panel. You may get a chance to ask questions as we go through, but the majority of the questions are going to be at the end in that Q&A panel. Oh, and of course, I'm giving UK times. I apologise for that. And then I will sum up for 5 minutes. So good morning or good afternoon, everybody. Now, you're not expecting this, so feel free not to, but I'd quite like folks who are here to say hi, just, we've not got a lot of time, so we might not get through everybody, but we'll just make a start, just to say hello, pronounce your name, because of course I will pronounce it wrong, and just say where you're dialing in from. That's probably enough information. And if you can put your camera on for that, it's a bonus. You don't have to. And if you don't want to talk, that's fine. Janaka, are you with us? You see, I've caught you off guard. So you might not be able to. You might not have the facilities. I know that. But if anybody has got the facilities, wants to say hi, maybe put your hand up.
I'm wondering, Stuart, whether it might be a thought to, I can see Professor Biplov from Dhaka, from BSMNU here. Hello, Biplov.
Yes, how are you?
I thought if you could just say hello to everyone and introduce yourself, maybe others might get inspired.
Okay, thank you very much, Adi. How are you? And I am
very well.
Professor Salahuddin. Yes, I am Salahuddin Kausar Biplov from Bangladesh and working as Professor Department of Psychiatry, Bangabandhu Sheikh Mujib Medical University. Welcome everybody, and just waiting to see the very good presentation of schizophrenia. Welcome from Bangladesh also. Thank you very much.
Okay, thank you very much, Biplov. And if anybody else can put anything on the chat, that will be a bonus for us. But without further ado, I will introduce from Colombo University in Sri Lanka, Madhu, or as she told me not to call her as we started, Dr. Dayabandara. Madhu, over to you.
Thank you, Stuart. Can I share my screen then?
Please go for it.
Hello, everyone. So I'm going to present some work which we have done in Colombo, and it's completed, but I'm presenting some preliminary data which we have analyzed, and basically on the outcome of schizophrenia in first episode and relapsing patients. And this was a one-year prospective cohort study, which we started from 2017, and the work has been completed last year. So we all know how devastating schizophrenia can be, and we know how it affects all aspects of higher order functions and all domains of social and occupational functioning in a person. But when you talk about outcome in schizophrenia, what really is good outcome in schizophrenia? Is it the absence of symptoms? Is it being able to hold a job? Is it being able to fulfill your social obligations? So there's really not a lot of consensus among the psychiatry, among psychiatrists all over the world, what really constitutes a good outcome overall in schizophrenia. This diagram, I know, is pretty complicated, and that is actually the idea that I want to give you. It is a complicated business, outcome in schizophrenia. We know that schizophrenia affects these domains: positive symptoms, negative symptoms, mood, cognitive functions, and there is a we all know that aggression is also a fairly large, it's a domain that we are also particularly worried about. Then there are lots of social demographic factors which affect outcome, and there are clinical predictors of outcome. And recovery in schizophrenia is not only remission or relapse, but it has to do with functioning in social and occupational spheres and the quality of life and your personal experience. So also we need to consider that whatever treatment is available at a particular point of time, and societal expectations also play a large part in determining what is conceptualized as a good outcome. Possibly we are not talking about outcome in the same way as in early 1960s. So the first outcome studies described something as an overall outcome in schizophrenia. But now we know that there is a shift from describing an overall outcome to outcome in different domains, such as in symptom domains, in cognitive functions, and in social and occupational functioning. The first significant study related to outcome in schizophrenia came from Manfred Bleuler. You may remember that his father, Eugen Bleuler, was the person who coined the term schizophrenia. He followed up a group of patients that he had treated since 1942 and reported that the outcome described by Kreplin was probably too bleak. And he described that almost 20% went into complete remission, and around 35% showed good social outcome at 10 years. However, around 24% still were disabled. This argument about whether outcome is good in developing countries actually came from, the evidence first came from Mauritius, and to a partly also from Sri Lanka from the beginning, where this particular study reported that the outcome described from developing countries was rather bleak, and the outcome in probably developing countries might actually be better. So the WHO set out to clarify whether it was true or not, whether outcome actually in developing countries was good or not. And they carried out 3 major studies. We know the IPSS, the DOSMED, and the ISOS. Let me briefly introduce to you, before going on to our study, what happened with the WHO studies. So the international pilot study in schizophrenia carried out and over a few years and published in 1973 was carried out in 9 countries across the world. And you will see Colombia and Agra in India and Ibadan in Nigeria were actually the 3 developing country centers that they reported from. It was actually carried out in 3 phases, in the first year, second year, and 5-year follow-ups. And they reported that outcome with relation to 3 aspects: percentage of time spent in with psychotic symptoms, social impairment, and type of remission, was overall good in or best in 17% and worst in around 19%. So we talk about maybe 1/5 with best outcome and 1/5 having worst outcome and the others falling somewhere in between. But they did confirm that in Agra and Ibadan, but not in Kali, the best outcomes, the percentages were more, somewhere around 43% and 33%, and the worst outcome, the proportion with worst outcome was less. Due to the criticisms of IPSS study, where they actually recruited people presenting, which was a hospital-based cohort, the DOSMED actually carried out in 86 and 1992 in 12 centers in 10 countries, where they included Japan also, was carried out in a community sample. And here again, they found that the outcome was better in developing countries. You can see that a mild cause of illness was there in 56%, whereas in developed countries, they reported 39%. And again, they did set out to see if the developing country discrepancy was due to the level of expressed emotion in these countries. And they did find out that in Denmark, it was higher, and in Chandigarh in India, it was around 23% and much less. The international study of schizophrenia in 2001, which actually again followed up and traced the original IPSS cohorts and 2 incidence cohorts, 14 new incidence cohorts, and followed up the cohorts from DOSMED and another study by WHO, reported that 50% overall recovered, but nearly 33% remained ill. And they talked about center effects, that the centers differed, that there was a heterogeneous outcome between the centers. And interestingly, similar to John Nash in, you might remember Beautiful Mind, there was a 15%, in 15% there was a late recovery seen at around 15 to 25 years. How about Sri Lanka? The first study originated in Kandy in Central Hill country in Sri Lanka, where a hospital population a retrospective study reported that 40% had not had any relapse over 10 years. The second study in the same unit where I carried out the study, again a retrospective 10-year follow-up, reported that 46% did not have a relapse and around 50%, half of them had good social outcome. There were 2 other studies. This one has again coming from the both, actually 3 out of 4 studies originating in the same unit as mine, reported that this group of patients on clozapine, that more than 80% actually had normal or minimal symptoms. And the majority, close to 50% of them were employed. And in a first episode psychosis cohort, which included all mood disorders also, that 56% had remitted. In this particular review, which I believe originated from Nimhans, they were, hypothesizing about what were the actual reasons for this difference in developing and developed countries. Is it urbanization? Is it social support, family structure, expressed emotions? There is some evidence that there might be genetic differences between countries. Chinese studies, they have reported more prevalence in women, and the early age of onset in schizophrenia was not found in some of the developing country studies, and the prodrome has been found to be less. And of course, we know there is less substance use comorbidity than in developed countries. And maybe the reviewers brought out the hypothesis due to the socioeconomic difficulties. Maybe there is natural selection of milder forms, and we might actually not see severe schizophrenia in the cohorts that we follow. So to think about all the difficulties in interpreting the findings of these studies, we know that there is no consensus on this outcome in developing versus developed. And the interpretation of data is difficult because of the difference in methods. And we don't have a lot of prospective studies except for the large WHO studies. Of course, several have been carried out later. And of course, we know that metabolic syndrome and obesity has a negative impact on the outcome. And this is something coupled with cognitive dysfunction that we need to think about when we are talking about outcome in the 21st century. So what we set out to do was we followed up two cohorts. One, an incidence cohort, patients diagnosed with schizophrenia according to ICD-10 research diagnostic criteria, presenting in their first episode, and the other, again, patients who are coming with a relapse with schizophrenia, who were coming in, present into our unit. Unlike in probably in UK or other countries, we are a walk-in unit where there are no barriers. So anybody presenting, even without an outpatient referral, if we find that the person has a serious mental illness, we will see then and there. Therefore, and also in Sri Lanka, community recruiting people for community research is very difficult, especially in schizophrenia, where the stigma is very much with relation to the illness. So therefore, people would not come out with a lot of details if we were to do a community research. So thinking about these difficulties, we resorted first to do a hospital-based study. So the first episode cohort was 119, the chronic illness or the prevalence cohort 118. We reviewed both cohorts at the baseline and at 6 months and at 12 months. Patients who were aged 16 to 65 years with a research diagnostic criteria, meeting criteria for schizophrenia were included, but we did exclude patients with schizoaffective disorder if there was any organic comorbidity or if there was comorbid mental retardation. And our sample size was 115 to accommodate for a dropout rate of 25%. We assessed almost all the domains with relation to schizophrenia: positive symptoms, negative symptoms, cognitive symptoms, mood symptoms, and all the metabolic parameters and social and occupational functioning. And all the tools were validated for Sri Lanka. The outcome measures were these. With relation to all the domains, and we contacted them over phone, gave them an appointment for follow-up. And if they did not come in, we arranged for a home visit if they were consenting. If that was not possible, then we had telephone contact and an interview. And only then, of course, if we couldn't even trace them that day, we considered that they dropped out. So these are the results. So 13, I had not, from the first episode cohort, I have not yet included in the analysis 13 samples. And at the 12 months, 27, but you can see that only 11 dropped out. And however, we know what was the outcome in the 11. 9 actually did not followed up. Again, at the 12 months also, 11 had dropped out. And 8 did not complete the follow-up, and 27 is we have to still analyze. So I'm presenting a preliminary analysis. The chronic illness cohort, of course, we managed to follow up more patients. If you look at the demographic characteristics of the sample, you can see that The two cohorts actually only differed significantly by age, and they did not differ in any other socio-demographic characteristics. Most of them were from the Colombo district, so a semi-urban population, semi-urban and urban population, not a rural population. The mean duration of the illness for the first episode cohorts was close to 3 months, and in relapsing patients around 3 years. We did not exclude comorbid substance use, but you can see that around 1/5 had nicotine or alcohol use disorders, and a fairly high percentage of 15% in first episode cohort had cannabis use, and in the relapsing cohort around 8%. So in the findings, we saw that the first episode cohort was more severely ill at baseline, but there was no difference according to gender. And they had more severe positive symptoms, they had more severe negative symptoms, but they improved much faster and their improvement was much better. So at the end of 6 months and 1 year, they were much less, having much less symptoms than the chronic illness cohort or the relapsing cohort. Remission and relapse, we defined according to working group, schizophrenia working group remission criteria by Andreasen in 2005. And it was a very, we used very restrictive criteria, and relapse criteria according to Olivares in 2013. And you can see that at 12 months, around 1/3 of them, of the first episode cohort had relapsed, around 1/4 of the relapsing cohort, and around 60% had achieved 64% almost at 12 months in the first episode cohort, but much less in the relapsing cohort, around 48%. Both non-compliance rates were much higher in the first episode cohort. And the most significant factor that we found for relapse was non-compliance. That was the only factor that we found to be significantly associated with relapse. Depressive symptoms were very significant at the baseline. So almost 75% of the cohort had significant depressive symptoms. And residual cognitive dysfunction was seen at baseline. It's interesting to see that it persisted even at 1 year for the first episode cohort, but it was more severe in the relapsing cohort. If you look at this study where normative data was compared with a group of patients with schizophrenia, you will see that the findings in schizophrenia is that, I would be interested to hear what Venkat has to say about this. The RBAL scores are around 1.5 to 2 ST below the normal population findings for the group with schizophrenia. The first episode patients actually did much better in all the scales than chronic illness patients. And you can see the domains which were most affected are attention and immediate memory and delayed memory. If you consider social functioning, then you can see at 12 months, around 55% of the first episode cohort were employed, and a little bit less, around 39% of the relapsing cohort. However, even though the employment rates were higher, you can see here that majority of them did not have any social roles in the marital or they didn't have a marital or a sexual role. That was concerning, even though most of them were, even though a fairly large proportion of them were employed. Looking at metabolic functions, the first episode patients actually gained more weight in 12 months. We were very interested in metabolic functions because of 2 studies which we have carried out previously in our unit, a randomized control trial on how metformin worked for weight gain, and which resulted later in a meta-analysis also. And you can see that the obesity rates in both cohorts were much higher than the age and sex adjusted rates in Sri Lanka. So it's usually around 14% for Sri Lankans for a population sample, and it's around 24% for first episode patients and 18% for relapsing patients. The prevalence of metabolic syndrome was separately looked at for males and females, and you can see the highest prevalence was for female patients with chronic illness, and for the first episode patients, it was higher for males. And if you look at the prevalence of metabolic syndrome in Sri Lanka, it's much less for males and females in the normal population. The mortality was, so we found that only 2 patients had died at this period, both due to cerebrovascular accidents at 12 months. Finally, if we compare the findings between the ISOS, India, and some of the findings from Ethiopia, you can see that our psychotic improvement with relation to remission and relapse rates and improvement in psychotic symptoms are much higher than what is reported by the International Study of Schizophrenia. But recently in an Ethiopian study, they reported that their remission for more than 75% of the time at 10 years was only 18%. If you look at the functional level, then of course our employment rates were much higher, but the not having a marital or a sexual role was very concerning. And if you look at the ISOS study, then these rates were higher than the overall findings reported. In an Indian study, to compare, around 52% and 48% were employed and with satisfactory social functioning at 10 years follow-up. Metabolic functions, so that is what is very concerning, coupled with cognitive dysfunction. Even though this particular study originated from, I think, Karnataka in rural India, actually reported that their metabolic syndrome rates, prevalences were much similar to the normal population rates. Our rates were much higher. So in summary, overall, our outcome may not be similar to the developing countries' outcome. So we might actually have better outcomes with regard to improvement in psychotic symptoms and relapse rates. But now in the 21st century, I think we need to think about social and occupational functioning and cognitive dysfunction. And particularly females with chronic schizophrenia, we need to be worried about metabolic syndrome. And I think the findings are that, you know, lots of psychosocial interventions need to go in for improvement of functional level with relapsing patients. Our study was supported by a grant from the National Science Foundation, and this is my team. Thank you very much.
Madhu, thank you very much. That was tremendous. Let me see if I can get press the right button to get my video on. That was fantastic. Thank you. That was lovely to hear. There's been an awful lot of work gone into that. I can see that. We'll pick up any questions, not for now, but for the panel, because we need to be cracking on. But if people do have questions, you can start putting them in the chat now, and then we're poised and ready for when the panel starts. But without further ado, thank you very much, Madhu. May I introduce the very impressive Venkat. Venkat.
So, good afternoon. It's indeed a great pleasure to be part of this program. Thanks, Adi and Stuart, for the invite. And following on a very excellent presentation by Dr. Madhu, I'll be talking some of our experiences with respect to the neuroimaging and the neuromodulation studies in schizophrenia.
Also, Venkat, can I just pause you there? What I haven't done is said is just said that you're Professor of Psychiatry at NIMHAN. So I just hope that you can just introduce you. Most people here know you, most people in the world know you, but for those that don't, a little sentence or two, rather than me trying to do it, would be appreciated to get us going. Thank you.
Right. Yeah. So I work at NIMHANS, and we coordinate this program of schizophrenia, which we call as individualized schizophrenia treatment and reintegration. So NIMHANS is the National Institute of Mental Health and Neurosciences, which is located in Bangalore, southern part of India. And we run this dedicated clinical research program for schizophrenia, in which we have a multifaceted approach in understanding and treating people with schizophrenia. And what I would be focusing in this specific talk would be looking at the neuroimaging and the neuromodulation related research work that we have been doing in our center. If you look at the theoretical postulates of schizophrenia, recently there has been a lot of interest in the disconnectivity of the brain circuits. Basically, if we extend it further, this is called as Bayesian disconnection, in which the predictive ability of the brain is impaired, somewhat similar to the concept of Bayesian statistics. So aberrant belief updating in the kind of higher cognitive processing has been proposed as a critical impairment in schizophrenia, and the frontal and parietal regional disconnectivity is something which is implicated quite critically. I'll just summarize a couple of neuroimaging observations that we reported from our center. We collected the resting state functional MRI data in a large cohort of drug-naive schizophrenia patients, along with my colleague, Dr. Shivkumar, who will be speaking next, and another colleague of mine, Sunil Kalmadi, who's the first author of this paper. So what we did in this study is we developed what is called as emphasis model, that is ensemble algorithm with multiple parcellation for schizophrenia prediction. And in this model, we found this kind of machine learning approach yielded a classification accuracy of 87%, which was fairly decent, especially comparing early course schizophrenia studies. Specifically with respect to the frontoparietal dysfunction that I mentioned in the earlier slide, we found robust connectivity in the postparietal and sensory motor network, which involves frontal, parietal, and precentral gyrus. And also we found auditory network as well as the anterior insula, which is implicated in higher level cognitive control and attentional processes showing hyperconnectivity. So there is concurrent hypo and hyperconnectivity. So these connectivity disturbances in the brain, especially in the context of schizophrenia, could be evolving and it could be modulated. And some of these aberrations in terms of different brain network connectivity and underlying neurochemical disturbances, whether it is glutamatergic, dopaminergic, or GABAergic transmission, they can be linked with the neuroplasticity abnormalities, especially because the signaling pathways have a lot of overlap. So that actually has been a major interest of our research group, the interface between schizophrenia and neuroplasticity. Neuroplasticity, as we all know, is the neurophysiological process through which the brain adapts to changing environment by altering its molecular and structural features. It was famously put forth by Donald Hebb as cells that fire together, wire together. And some of the initial studies that we reported over the past couple of decades, in one of the first reports, we documented deficient insulin-like growth factor in the serum of patients with antipsychotic naive schizophrenia patients. And later, we also reported brain-derived neurotrophic factor deficiency in schizophrenia patients, especially in those that have fluoride-positive symptoms like first-rank symptoms. So as we know, the insulin-like growth factor as well as the brain-derived neurotrophic factors, they are critical neuroplasticity modulating molecules. And we also went on to explore whether some of the neuroplasticity gene polymorphism has any meaningful relationship with some of the critical brain regions implicated in schizophrenia, for example, hippocampus. So we did find some evidence, and also we concurrently evaluated whether these neuroplasticity abnormalities co-occur with other inflammatory abnormalities, in which we found interleukin-6, a pro-inflammatory cytokine, to be aberrantly higher in people with schizophrenia. And interestingly, the interleukin-6 is also implicated in the metabolic abnormalities, which Dr. Madhu nicely illustrated in her talk. So the kind of model that we are working has multiple components. We believe that the gene and environmental interaction results in the persistent activation of glial cells in the brain. So this is something which we have borrowed from the fundamental research that is available. And such persistent aberrant activation of glial cells might be associated with a pro-inflammatory state, for instance, increased levels of interleukin-6, which Shiv will be explaining in much more detail. And this in turn can result in deficient neurotrophic factors, for instance, brain-derived neurotrophic factor or insulin-like growth factor. And together, these neurobiological aberrations can result in abnormality in neuroplasticity, which in turn can contribute to brain network aberrations like the frontoparietal disconnectivity that we found using the resting state functional MRI. And such connectivity deficits can lead to cognitive deficit, which in turn can be the basis for the clinical manifestations of schizophrenia. So what we have been interested is to explore concurrently some of the interventions that can modulate neuroplasticity. So that is the context in which we became interested in the transcranial direct current stimulation, or TDCS, which is an intervention that is based on a relatively simple principle that a weak direct current can modulate neuroplasticity. TDCS, that is transcranial direct current stimulation, is a non-invasive, safe technique that involves application of low intensity direct current in the range of 1 to 2 milliamperes. And this current is delivered using bioconducting electrodes placed on the scalp. The proposed mechanism is such current application might cause polarity-specific neuromodulation, and which in turn can lead to adaptive neuroplasticity changes. The advantage of this neuromodulation technique is because of its portability in terms of the device structure, and also it's much cost effective compared to other neuromodulation techniques. A brief note about the mechanism of TDCS. TDCS has two current components. One is the anode, which is the positive current. The other one is the cathode. So what we see here is the depiction of effect of anodal current on the action potential. So as we see, once the anodal current is switched on, the frequency of action potential increases. And once the anodal current is switched off, the action potential returns to the baseline frequency. It is very important to note that TDCS by itself does not cause a de novo or a newly generated action potential. Rather, it shifts the resting membrane potential. That is, an anodal current makes the resting membrane potential relatively more depolarized so that the frequency of the background action potentials increase. On the other hand, when a cathodal current is applied, the reverse happens. That is, the resting membrane potential becomes more hyperpolarized so that the frequency of action potentials may decrease, or it may even cease to happen. So this is one component of TDCS mechanism. The clinical significance of this mechanism is Since TDCS does not cause a de novo action potential, the risk for seizure as an adverse effect due to TDCS is extremely unlikely. So that makes it even more safer, in addition to the portability and cost effectiveness. Some of the other mechanistic components of TDCS involves the GABAergic and glutamatergic influences, as well as TDCS is shown in several fundamental research to cause BDNF, which is a molecule which is critically implicated in neuroplasticity, changes in the BDNF mechanism. So if you look at the TDCS mechanism, it has multiple levels, starting from the resting membrane potential alterations, neurotransmitter alterations, and certain neuroplasticity and calcium signaling related alterations. So we have been running this TDCS clinical research program, which we call as WISER Neuromodulation Program, which is the acronym for Weak Intensity Stimulation for Enhancement and Reintegration. A colleague of mine, Dr. Janardhanan, and me, we have established this clinical research service. In addition to schizophrenia, we have been successful in applying TDCS across several other psychiatric disorders. I'll just emphasize some of our work in the area of auditory hallucinations in schizophrenia, where we have used TDCS as an add-on treatment. So if we look at the simplistic description of the brain basis of different symptom components of schizophrenia, the negative symptoms, which involve emotivation, avolition, alogia, is shown to be associated with hypofrontality. On the other hand, the positive symptoms like delusions and hallucinations are associated with aberrant hyperactivation of the temporoparietal junction. So if you look at this simplistic depiction of abnormalities, at one region of the brain, we have aberrant hyperactivation. At the other region of the brain, we have a hypoactivation. So it gives a nice case for applying TDCS, in the sense, if we use cathodal current, it is possible this aberrant hyperactivation can be inhibited. And on the other hand, the anodal current may enhance the function of the hypoactive brain region, that is the prefrontal cortex. So this is the basis with which the TDCS montage is designed. In the sense, the cathodal electrode is placed on the scalp region, corresponds to the left temporoparietal junction, which is shown to be aberrantly hyperactive in people that have positive symptoms like hallucinations, whereas the anodal electrode is placed in the scalp region corresponding to the left dorsolateral prefrontal cortex. The TDCS protocol involves application of 35 centimeter square electrodes, which is covered with saline spoke sponges, and the duration of the treatment is about 20 minutes, and we use, at least in this particular report, we have used twice daily sessions with an intersession interval of 3 hours spread over a period of 5 days. So this is the schematic description of how the current is delivered. There is a ramp up or a slow increase in the current, and after that it reaches the peak amplitude of 2 milliampere, in which it persists for 20 minutes, and then it is ramped down at the end of each treatment session. So we have been using structured adverse effect evaluation questionnaire. And in the past many years, we have delivered across several psychiatric disorders more than 5,000 individual patient sessions. So this is in terms of sessions, whereas the number of patients wise, we might have given TDCS for close to 500 patients. And in almost all sessions, the TDCS was very well tolerated. So that is one very impressive and encouraging observation. With respect to the effect of TDCS on auditory hallucinations, we reported using a randomized double-blind sham-controlled study in which both Anushri and Shiv did a major role. and in which we showed that an add-on treatment with TDCS resulted in nearly 30% reduction in the persisting auditory hallucination in the true TDCS group in comparison to the sham. And one interesting observation we had was in those sham-treated patients that did not improve in the RCT phase, that is a randomized controlled trial phase, when we shifted them to open label phase, almost all of them again showed good improvement. That is, the mean reduction in the symptom was close to about 28%. So essentially, yeah, it is about 29.5% happened when they were shifted to the open label extension phase. So this was a kind of encouraging observation, which has made us to use TDCS more often to treat persisting auditory hallucinations in our clinical setup. So this finding is comparable to what was reported by Brunelin and colleagues from France. And a quick word about some of the advanced application of TDCS in which we are combining the neuroimaging and neuromodulation. I thought I will give this illustration mainly to depict the translational utility of combining different techniques. So in the TDCS trial, what we found was there were some patients who did not improve, and there were many who showed very significant improvement. So we chose two patients, one who had a near total improvement in auditory hallucination and another patient who showed minimal change in auditory hallucination, though we gave near identical treatment protocols. So as a post hoc analysis, we used their structural MRI and did some computational neuromodeling analysis step, essentially to predict the profile of the current intensity peaking. So where the electricity would have peaked in a particular individual given this kind of brain morphology that is inferred from the structural MRI. What we found out was in a person that showed excellent response, the peaking was bang on the left temporoparietal junction in which we wanted the current to be peaked, whereas in the non-responder, the peak was much distal. So this is the work which is done by my colleagues Sunil and Gaurav, and it essentially shows that the inter-individual variations in brain anatomy could be one of the factors that influence a TDCS clinical outcome. Perhaps in future, if we have to have a priori analysis of brain structure and model the current spread, the electrodes could be placed in a different way with a simulation informed position so that the current peaking can be made to happen in the desired region. Coming to the last part of my presentation, there have been some optimizations of the transcranial direct current stimulation in contrast to the conventional technique which uses a larger electrode. The high definition or the HD TDCS uses a much smaller electrode which gives a focal current peak so that the controllability of several parameters becomes more optimal. So we have been using high definition TDCS to treat auditory hallucination, and the initial set of open label studies, we have found some very encouraging results. So this is the set of studies that we reported using high definition TDCS done by our colleague Dr. Sriraj. Coming to some of the future direction, while using the brain imaging or some neuromodulatory techniques like TDCS may make it appear a major challenge like schizophrenia can be managed much easier. Of course, we learned from our experience that there are inter-individual variations and we need to work more to understand and treat the person much better, which essentially emphasizes this profound statement by Lyle Watson: if the brain were so simple we could understand it, we would be so simple we couldn't. So with respect to TDCS, the future research we want to combine, which we have been doing in terms of both neuroimaging and the neuromodulation, and several other electrophysiological as well as the wet lab-based polymorphism and several other factors, and which also includes the state-dependent factors, to see what are all the potential influences of these host of factors on the clinical impact of TDCS. We hope to use over the course of time neuro navigation and neuroimaging informed neuromodulation. There are some PhD work which is in the process of completion using such advanced technique, and with which we hope to develop a more predictive model which can help us to refine the application of TDCS. So this is the kind of summary points which I wanted to emphasize, starting from the frontoparietal disconnectivity to neuroimaging and neuroplasticity, and a modulation of neuroplasticity using this neuromodulation technique. So with this, I wish to stop and acknowledge a team of colleagues that work with us both at the clinics as well as in the lab. And actually they do all the difficult part of it, and I take care of the easy part, that is talking about it. And with that, I'll stop, and thanks again for this opportunity. It has been wonderful. I look forward to more interaction at the end of this program. Thank you. Thank you.
Thank you very much. It's absolutely an amazing body of work, and the potential that intervention is just tremendous and so untapped, and we could really make a difference to patients in the way that we don't. Now, that last or penultimate slide that you had, we will hopefully be able to get a chance to come back to that, and because we've got a little bit of panel time at the end, and we'll see if you can get that slide back up, and we can go through that, because there's an awful lot in there that you just didn't have time to tell us. And there's no way you could have packed all of that into such a short space of time. That absolutely fantastic, amazing. Now, thank you very much. And Shiv's next. Shiv, same again. I'm not going to introduce you other than say Shiv next, but I'd like you to do that. And we're a little bit behind time, but that's fine, because we can steal a bit of panel time so that you've got space to say what you need to say. So over to you, Dr. Kumar. Thank you very much.
Hi, thank you, Dr. Stewart. Can you see my slides?
Yes, perfect. Yeah.
So good afternoon and good morning, everyone. So I'm Shiv Kumar. I work as a scientist at the Department of Integrative Medicine, and I'm also an early career fellow of DBT Welcome India Alliance. So this is a research project, which is a joint collaborative project between NIMHANS and Newcastle University, funded by DBT Welcome India Alliance. So the title is a little long, and so is the study. It's cognitive dysfunction and sleep dysregulation as endophenotypes of psychosis, a study of neurophysiological, neuroimaging, and neuroimmune correlates. So the investigators are from both NIMHANS as well as the Newcastle University. So these are the investigators. Now, coming to the neurocognition and sleep disturbances in psychosis. The previous studies, previous speakers have already introduced about psychosis, and they've spoken about how cognitive dysfunction is a big problem in psychosis, because it is one of the most intriguing, challenging, and rate-limiting factors we face today in treatment. It's a tough nut to crack. And neurocognitive impairment is a common feature in severe mental illness, contributing to a significant socio-occupational dysfunction. And despite years of research into it, the etiopathogenesis and prognostic relevance is poorly understood. And this neurocognitive deficits, interestingly, is state independent, occurring in asymptomatic patients as well as in the unaffected first-degree relatives. In fact, you might have read recent reports in which researchers claim that the greater emphasis on psychosis has been a conceptual fallacy, and which might have limited our understanding of psychosis. Nevertheless, this emphasis on cognition in schizophrenia is due to the growing body of research suggesting that cognitive function in schizophrenia is one of the most critical determinants of the quality of life and function in schizophrenia, even more so, more than compared to that of the psychotic symptoms. Now, when we talk about cognitive deficits, there is a lot of domains of cognition which are impaired in schizophrenia, like processing speed, attention, executive functioning, learning and memory, language function, and emotional processing. However, although the pattern of deficits appear to be broad, the hierarchical organization of cognitive processes suggests that many problems may be secondary to the deficits in the core domains of cognition, such as attention or basic processing speed. So these deficits in the attention or the basic processing speed, like I mentioned earlier, is also found in the early phases of the illness, as well as in the unaffected first degree relatives. So this might serve as a potential end of it. So now coming to the further dwelling into the cognitive deficits, what the understanding what we have about cognitive deficits so far is mainly the measurement of reaction time, so the mean reaction time as well as the accuracy. So majority of the tests so far conducted in by several research groups have mainly looked at the computerized tests or other modes examining the mean reaction time to demonstrate the speed of processing. However, the research into reaction time slowing in psychosis, although it has given us a basic understanding, the mean summaries of just the use of mean summaries of variability is is frequently criticized, because there is a lot of within person variation which is seen especially in psychotic patients with psychosis, in which scenario the mean reaction time might not give us a real picture of group differences. And also in some of the reaction time measurement in complex tasks, the reaction time varies over time, which cannot be mapped using this the mean reaction time. So in this context, recently many researchers have resorted to certain advanced measurements such as intra-individual variation in the reaction time performance. So the processing speed based measures, which cannot be mapped using the mean reaction time, can be optimally characterized using the intra-individual variation, especially the top parameter of X-Gaussian modeling, which I'll get into in the next slide. So first, let's just understand what is intra-individual variability. Intra-individual variability is a variability within an individual responses to the same stimulus during a single task session or to the same task across multiple sessions. So it means when a patient attempts a task, over time there is a significant time to time there is variation in his performance, which cannot be mapped using the average reaction time. So as you can see, so to address this, there are techniques called X-Gaussian distributions, which is a positively skewed unimodal amalgam of an exponential and Gaussian distribution. To understand better, as you can see in this figure, which is from one of the publications from the Newcastle University itself. So as you can see here, the green the curve indicates a Gaussian distribution, which we normally see, which we normally map, that is the mean reaction time. But there is something called as the top parameter, which is the blue line, which is not generally measured using this average reaction times. So the X-Gaussian distribution, which is the red curve here, actually maps the top parameter as well, giving the real picture of the slowness in the reaction time performance. So I'll not get into the deeper details. The reason why I gave this introduction to this intra-individual variability and X-Gaussian model is we are in this study, we are involving these parameters to understand the attention processing better. Now, coming to sleep dysregulation. So the cognitive deficits and sleep dysregulation are critically linked. So the sleep dysfunction, as we all know, has been observed across psychiatric disorders. So in addition to the overlap, what we see of psychotic symptoms in schizophrenia and bipolar, sleep dysfunction is another common finding what we see in these two disorders. Of late, there has been a growing interest in conceptualizing sleep dysfunction as a transdiagnostic process which might have a shared cognitive or neurobiological underpinnings, which might help us devise better treatments. So the sleep disturbance has been noted, the prevalence of sleep disturbance has been noted in 36 to 80% of patients with psychosis, as per the recent meta-analysis by Carruthers et al. And the poor sleep quality and maintenance, poor sleep quality, sleep maintenance, and irregular sleep-wake cycles are the most commonly reported abnormalities in patients with psychosis. Now, further evidences has suggested that sleep impairments even precedes the onset of the psychotic symptoms in first episode psychosis. And some studies have also gone to an extent that the sleep disturbances can even predict the acute decompensation in patients. These are also based on some of the evidences wherein people have shown that prolonged sleep deprivation can even bring about psychosis-like experiences in healthy individuals. And sleep disturbances are also found to be pervasive in individuals at high risk for developing psychosis. So sleep dysfunction is not only consistently observed in patients with psychosis, but it may also be implicated in the genesis and persistence of this disorder. So now, how is sleep and psychopathology linked? How are they related? So there are a couple of theories. I'll mention two of them. One of the theories are the residual psychotic symptoms, including hallucinations, paranoia, and subthreshold symptoms of mania and depression, interfere with sleep induction, which in turn disrupts the sleep, and which in turn, as a vicious cycle, brings about or aggravates the residual psychotic symptoms. Second, many studies have demonstrated that there is a reduced daytime motor activity, which results in attenuated sleep pressure as a result of naps and daytime inactivity, which together destroy, or which together affects the circadian rhythm of the sleep. So this results in further sleep disturbances. Now, we spoke about sleep dysfunction, sleep dysregulation, and cognitive deficits. Now, how are these two related? So, studies have shown that patients with irregular rest activity cycles, that is, those who frequently nap or sleep during the day, and who wake up often or sleep poorly during the night, were found to exhibit worse cognitive performance compared to those with normalized rest activity cycles. So the studies are quite limited in this area, but with the limited cross-sectional and case control studies, it has been shown that the various aspects of sleep, that is the sleep quality, REM density, and sleep spindle density, are negatively associated with cognition, such that the greater disruption to sleep, greater is the recorded cognitive deficit. So, like I mentioned, sleep and circadian rhythm disturbances are frequently observed in mood disorders as well as psychotic disorders. And in fact, there are a couple of studies which also say that the neuropsychological impairment in recovered bipolar patients is confined to those with abnormal sleep patterns. So, having said this, there are, like I already mentioned, there is a dearth of literature examining the relationship between sleep and cognition. There is, although there are few good sample size based studies, despite that, there is a lot of methodological heterogeneity. And further, if you look at these studies, there is no consensus on the extent of relationship between the sleep and cognition in psychosis. Whether the disturbed sleep in psychosis is a causal mechanism responsible for cognitive deficits, or if the impairments are made worse by sleep disturbances, is something which is not clear. To add on to that, there is no research which has established whether acute or more chronic sleep disturbances differentially impact cognition in this population. So this calls for a rigorous research into these areas. Now, we spoke about sleep dysregulation, cognitive deficits, and their relationship. Now, what are the neural correlates which bring about the cognitive deficits due to sleep dysregulation? So, how does sleep disturbance affect the brain, in turn affecting the cognitive processes? So, there are a few studies, neuroimaging studies to be precise, which have made an attempt at elucidating the same, especially the structural and functional connectivity studies, specifically the white matter integrity studies. So, as we all know, white matter integrity is critical for efficient cognitive functioning, especially for cognitive tasks involving attention and memory, which depend on widely connected neural systems. So a couple of studies have reported a strong link between white matter integrity and the intra-individual variability, which I was mentioning earlier. So, we all know that white matter, the structural and functional connectivity is affected in patients with psychosis compared to healthy individuals. And also these deficits are also found in first degree relatives of these psychosis patients. So there could be a critical link that exists between sleep and cognition that could be mediated by alterations in white matter, which remains largely unexplored. So further, there are no data relating to the sensitive measures like intra-individual variability in attentional response times while examining the high definition assessments like structural and functional connectivity, elucidating the pathophysiology. Particularly, there are no data in the cohort of subjects with devoid of the effect of psychotropic medications. Now, I'll come to one other aspect, which is the impact of aberrant immune system. You are fresh with Dr. Venkat's slide about the gene-environment interaction and how the IL-6 and other cytokines can have a long-lasting impact on the brain and behavior. So, aberrant immune system is something which is a hot topic of research in psychiatry. In fact, there is if you type what's hot in schizophrenia, you will get immune aberrations and inflammation as one of the hot topics. So dysregulated immune system is an important vulnerability factor for psychosis, and it has been in the forefront of pathophysiology of psychosis. And this aberrant immune system can be measured using peripheral cytokine secretion, which some studies have shown that the immune aberrations, especially the changes or increased or decreased cytokines, can have an impact on the structural and functional connectivity. In fact, there are studies which have also examined the relationship between the aberrant immune system and the sleep dysregulation. So with these concepts in mind, this is the rationale for the study. We saw that the cognitive dysfunction, a common feature in psychosis, to be present in all phases of the illness, as well as in unaffected first-degree relatives, which has a critical link with sleep disturbances, and the neural correlates of which could lie in the structural and functional connectivity changes. So the aberrant and these data suggest that sleep dysregulation may, via an immune-mediated mechanism, may disrupt the structural and functional connectivity, and thus causing impairment in sustained attention, which might further result in broader pattern of cognitive impairment seen in patients with psychosis. So this is the rationale with which we are going. So coming to the objectives of the study is to characterize the profile of sustained attention deficits, the sleep and circadian pattern, white matter integrity, as well as the functional connectivity and immune functions in first episode psychosis patients and the first degree relatives in comparison to healthy ones. And to model the relationship between these parameters in first episode psychosis and to examine the endophenotype potential of the proposed parameters. The last objective is to understand the prognostic implications and the effects of antipsychotics on cognitive deficits in first episode psychosis. Coming to hypothesis, the hypothesis has been split into primary and secondary. So the primary hypothesis is to look at the deficits in sustained attention, the sleep pattern, and white matter integrity and immune function, which will be in the order of patients greater than first degree relatives, greater than controls. So which will be controls, and there will be a significant interaction between these parameters. And the secondary hypothesis will be that the immune aberrations mediate this relationship, and the antipsychotics will significantly improve the aberrations in cognition, sleep, and brain connectivity and immune parameters. Coming to the methods, sample size was estimated based on the sustained attention deficits in psychosis with 90 subjects in each group. And this is the study design, wherein drug name or drug-free patients. First of all, this study comes with two arms, that is the cross-sectional and a longitudinal arm. The cross-sectional arm will be a baseline comparison between controls, first-degree relatives, and patients, and the longitudinal arm includes reassessment of clinical, cognitive, sleep, and immunoassays and neuroimaging after 3 months of treatment with antipsychotics. I'll briefly rush through this. The subject selection, that is the inclusion criteria, will be diagnosis of psychotic disorder, duration of illness less than 2 years, although we had to revise this because of the present COVID situation and non-availability of patients, and drug name or drug-free status, and written informed consent. And these are the exclusion criteria. Then unaffected siblings will be the first-degree relatives of patients with ICD-10, schizophrenia, bipolar 1, or psychosis. And exclusion criteria will be diagnosis of psychosis or any other axis 1 disorder in the subject. Healthy controls seen. The exclusion criteria will be diagnosis of any psychiatric disorder or family history of any psychiatric disorder in the first degree. The assessments are clinical, cognitive, and other neuroimaging and sleep assessments, clinical, mini to rule out any other diagnosis, then SANS and SAPS for psychotic symptoms, Young's Mania Rating Scale, HAM-A and HAM-P, and for comprehensive assessment of at-risk mental states for the unaffected relatives, and socio-occupational functioning scores. Then coming to the cognitive assessments, we will be looking at Hindi mental status examination, then psychomotor vigilance task, which is one of the most important tasks in this study, and matrix equivalent battery tests for processing speed, digit symbol substitution test, category fluency, and trail making test A and B. Then for attention and vigilance, we'll be looking at 0 back and 1 back. For working memory, spatial span, letter number sequencing, and reasoning and problem solving, cover of London. And for social cognition, we have a in-house task called as trends, wherein we project faces with emotions of fear, anger, sad, and disgust, and we ask them to match and label the emotions. Now, one of the main highlights of this study is to objectively assess sleep and circadian rhythm in study participants, in addition to self-reported questionnaires. So the sleep or the actigraph data will be collected using wrist-worn accelerometers for a period of 3 weeks, which better assesses the sleep and circadian rhythms than probably the polysomnography, which is done for a day or 2, and more importantly, this is done in home environment. So, and this will be coupled with sleep logs, which the patient will be maintaining, and these two will be compared, and then the measurements like hypersomnia or insomnia, circadian rhythm disturbances will be measured. Coming to data analysis, a standard set of tools will be used. Sleep R package GGIR algorithm will be used. For attention tasks, like I mentioned earlier, reaction time data will be analyzed according to X-Gaussian distribution. fMRI using SPM and QAM, and DTI will be FSL-based TBSs, and advanced NODI analysis will be performed. NIMHANS, the feasibility and expertise wise, NIMHANS has high attendance of walk-in medication, naive or free patients. Until now, it was relatively easy. With the COVID, there has been a lot of difficulties. And we also have a research exclusive 3T MRI scanner, which facilitates immediate assessments. And Newcastle University has been providing, Dr. Stewart, Dr. Adi, and others have been providing state-of-the-art facilities and inputs for cognitive research and sleep studies. And yeah, and coming to the outcomes and implications of this project, the results can potentially generate a dimensional characterization of first episode psychosis, delineating how different factors can impact the prognosis. This might also reveal the effect of antipsychotics on cognition and probably its mechanism. So this might have significant clinical implications in early intervention, especially for the unaffected FDRs. So early intervention might help us mitigate the treatment refractoriness, at least to a certain extent. Thank you.
Shiv, thank you very much. Tremendous. Let's get my camera on. So we've got 12 minutes left for some questions, and I'd encourage people to put their hands up or put stuff in the chat. Adi is the only chatter so far, and I don't know whether that's because the people haven't got access to the chat or whether you're holding yourself back. But if anyone's got any questions, shout them out, put your hand up, or put them in the chat. Shiv, what I really like about that is it's just that recognition that all of these things that we're looking at and we're measuring, immune function and brain connectivity and sleep and neuropsychological performance, all interact, and the sort of I suppose that takes away that naivety of measuring. You know, why measure? How can you measure immune function if you're not measuring sleep at the same time? And that when the two are so enmeshed, so it's lovely to see that at baseline measuring all of those, and then with the longitudinal follow up as well. And what's also nice is to present it at this point. So present it as a work in progress rather than waiting until the study's finished. I think it's so nice to see what people are doing and what works going on. Could you let us all know how far through you're aiming for 90 people over the fullness of time? You've had a pandemic to negotiate, which must have made it so difficult to do this study. Have you been able to recruit many people, and how has it felt?
Yes. Off late, since the last couple of months, we have been quite lucky that we got close to some 8 patients and 5 FDRs, the first degree relatives. So the problem is many a times it so happens that many of them who we recruit, since they are first episode psychosis, drug naive, drug free, many of them opt out in the middle of the assessments. So that has been quite a bit of challenge. And for the first degree relatives, it's a couple of them have backed out because of the fear of COVID. So this is something which has been quite challenging for us because they have to lie down in the scanner. So some of these things have been a little difficult. And moreover, just to mention, there is a lot of checks in place here as well to prevent the spread of infection. So the subjects whom we are recruiting have to undergo rapid antigen test before getting into the scanner and other assessments. So many of them back out at that stage as well. Right. That has been a little challenging.
And does it feel like that's getting a little easier now than if you've had a successful month?
Sorry, can you come again?
Does it feel that those COVID challenges are getting a little easier now, or do you think they're going to dog you throughout be a problem for the whole of the study?
No. I think that's what I said. Since last couple of months, these things have been eased out. So, we got a few subjects. So probably now that the cases are raising, I think it's going to be a waxing and waning phase of recruitment, probably what we are looking at. So sometimes we do get patients, and sometimes.
Yeah. Such is recruitment, such is clinical research.
And one more thing I'd like to mention is we have a host of assessments, and many a times these patients do not cooperate for all the assessments. Completely understand their perspective. So whatever we could do, we have been.
Yeah, that makes perfect sense. And I don't know whether Madhu's still here, because what I'd be really interested in, Madhu, is your thoughts. So having in Colombo, having done that beautiful study of following people up over time, does it feel to you that I suppose that Shiv's getting it right? All those parameters that he's looking at: sleep, immune function, brain connectivity, neuropsychological performance. Does it feel, when you think about your patients who you've been seeing, do they feel right? Do they feel like they're going to interconnect? Do they feel like they're the important things to be looking at in people with a first episode psychosis?
Definitely, Stuart. I mean, I think from what Venkat presented and what the work that Shiv is doing, it kind of, all connects together. And I think what I have probably looked at is the final, sort of, how does it all come together and present in real patients, whereas their work is, making sense in, understanding what is happening with everybody who is, suffering from schizophrenia. I was really interested to hear, I think it was in Shiv's presentation, that in bipolar patients, that sleep dysfunction and cognitive dysfunction is very strongly linked, isn't it? And that might be one area where we can intervene when, when you know that, sometimes maybe antipsychotics only might not help.
Yeah, no, absolutely, absolutely. I mean, the findings in Newcastle were so stark that those people with bipolar disorder who had normal sleep had normal cognition, and the people that didn't sleep had aberrant cognition. But what you say, Madhu, is really nice, and I think speaks to the genius of Adi bringing everyone together and the glory of NEESAMA bringing people together, because like you say, looking at the same thing from different angles in different countries, and sharing what we do is so nice, and is the only way that we're going to progress and make things better, I think. So well done, NEESAMA, and well done, Adi. I'm just firing, Clay. I've got so much that I'm sort of aware that we've not got an awful lot of time. Adi, go for it.
I've just got to ask, Madhu, a fascinating talk. I remember doing psychiatry in Delhi and reading about the studies that you were citing, that it was conventionally thought that the outcomes for psychosis and schizophrenia were better in less developed or developing countries compared to the developed countries. But I know you presented such an elegant sort of progression of that. Just given the work that you're doing and the raw data that you have access to, do you think that sort of important inference at the time was an artifact of how outcome was defined at that time? Is that your gut feeling? And does more work need to be done, what Shiv and Venkat's lab are doing to look at mediators of and predictors of outcome?
I think, Adi, you just put the finger on what I think I was just, formulating in my head. Yes, I think we didn't really understand the illness at that time. And it's all, coming together only now. And I think you can't really understand schizophrenia in terms of just symptoms and, social functioning. We have to, and some of the people in whom I had detected very significant cognitive dysfunction, they actually had fairly satisfactory, employment rates, and, they were married, but, their functional level was in the sense that, I felt that, they were really not well adapted, and, their social roles were, not very, fulfilled and all that. And maybe what Shiv and Venkat is looking at is what is contributing to all that. And I think that, you really can't define outcome like that. And maybe it needs to have more, we need to look at more aspects, and probably we might not be able to just define it as an overall concept. We probably might need to, look at it from different angles.
Thank you, Madhu. I just wondered, Venkat, if you had any thoughts. You've been researching this field for, and beautiful body of work. Just any comments about that?
I think more and more research suggests if there is an early and effective intervention, the first episode psychosis, the remission rates are pretty good. And now I think if you look at the UFEST data, that also supports. So perhaps one of the factors that might have influenced the earlier study findings could have been a lack of early intervention. So that is, and what Dr. Madhu mentioned in terms of distinct difference between the first episode cohort versus the chronic cohort perhaps supports that view. And I fully agree that we need to have a more inclusive approach where we have the symptoms, a comprehensive assessment of symptoms, cognition, and neurobiology. But the neurobiological research studies should also look at certain techniques and parameters which are scalable. So that is where it is. I think that's where some of the work which Shiv has initiated in collaboration with the Newcastle team is very interesting, especially looking at some of the active edge and how we can link it with the sleep, which is a very important variable that can influence the cognition and symptoms. So these are my quick thoughts. Thank you.
Thank you very much. Back to you, Stuart.
Yeah, I just want to say one thing. I just want to go back to that TDCS work, which just has bowled me over. And you're talking about early remission, early treatment, and TDCS just seems such a good way of doing that. And if we can, Madhu's got people walking in from the clinic. We put all kinds of barriers in between patients and doctors in the UK, but people walking in and having TDCS, it turns things on the head. So the potential here in first episode of Psychosis, I think, is tremendous. Adi, we're finished. I know we've got a minute left. I saw you were on the move. Are you able to wrap us up?
Oh, yeah, absolutely. No, thank you. I was just going to say as well, Stuart, you've almost set us up for, I also know that Professor Biplov is here from Bangladesh, and I'm wondering whether there is a potential study emerging out of this webinar, looking at the feasibility and acceptability of TDCS across 3 different South Asian countries and potentially even the northeast of England. I think it is, as Professor Venkat said, something that is scalable, something that works in that context. And yes, maybe there is a call coming out, by the way, in the next month. Maybe I'll set up an email loop to discuss this further out with the webinar. But thanks, Stuart, for chairing. Thank you to all 3 of our excellent speakers, obviously hand-selected and invited. I would like to particularly thank Professor Madhu for suggesting the topic as well and proposing that. And the 3 talks just enmeshed so beautifully, going from outcomes to the neurobiology into a very discrete project that Shiv is trailblazing with. So thank you very much. Just to everybody who logged on, huge thanks. NEESAMA is a vibrant young community. We've only been in existence for about 4 or 5 years. I've put on the chat, we have a website. Please look us up. And if any of you would like to join the community so you're up to date with future webinars, conferences, we're planning a series of training events, just let us know and we can keep you in the loop. As long as you wouldn't mind maybe 1 or 2 emails a month coming into your inbox. So again, just wanted to end with thanking Stuart for chairing, Shiv, Venkat, and Madhu. Huge thank you. Please stay safe, everyone, and take care. Bye.
Thank you very much.